Welcome back. Today we will be starting our coagulation unit. Our slides today will go over the introduction to hemostasis and just a few brief overview of the entire coagulation system. You may be wondering, what is hemostasis? Hemostasis is the process of forming a barrier to blood loss and limiting it to the injured site. Hemostasis occurs in three stages: primary phase, secondary phase, and fibrinolysis. As I mentioned in the previous slide, we have three phases of hemostasis. Our initial phase of hemostasis is primary hemostasis, and this is a result of the actions of blood vessels and platelets collectively during hemostasis. Typically, we see this occur initially when injury has occurred, and it is kind of the first response to injury. The second part, or the second phase, is secondary hemostasis, and this is a result of the actions of the protein coagulation factors to form the fibrin that becomes a part of the clot. So these protein coagulation factors are in circulation in the body at all times in an inactivated form, typically, and then they become activated due to the response of that injury. Fibrinolysis is the process of removal of fibrin. So once we've formed the clot and our injury has healed, fibrinolysis removes that fibrin, breaks down the clot so that we don't have repeated clot buildup within the system. This resolves the clotting process. The first component of hemostasis that I'd like to talk about is in regard to our vasculature, or our blood vessels. We have three types of blood vessels that are important to know about. Our arterioles, or you may have heard them called arteries. They are composed of smooth muscle, fibroblasts, and a thick wall of collagen. The second are venules. These may be referred to as veins. They are composed of less smooth muscle than the arterioles, fewer fibroblasts, and a thinner layer of collagen than we see in arterioles. And then the smallest blood vessels that we have are capillaries. These are the blood vessels that are closest to the surface of the skin. They are also the smallest vessels, and they are only composed of a small single layer of endothelial cells. When we have a breach in any one of these blood vessels, we have a hemostatic response. So let's kind of talk about that as we go along, because our blood vessels actually do play a role in the attempt to stop bleeding. The second component I'd like to talk about of hemostasis are platelets, and these are imperative for proper clotting. We've talked a lot about platelets, both in our red blood cell unit and in our white blood cell unit, but this unit is going to talk specifically about the behavior, the physiological response of platelets, and their very distinct role with regard to hemostasis. So as we know, platelets are derived from that cytoplasm of the megakaryocytes. And for the most part, they're pretty inert until activated. They are disc-shaped. And a normal platelet count for a healthy individual is about 140 to 400 per microliter. And that is in thousands. Remember, this is scientific notation. The interesting thing about platelets is they have a very short lifespan, only about 8 to 12 days while in circulation of the peripheral blood. So platelets are often used up, but they're also replenished frequently. We have some really important proteins in our body that are imperative components of hemostasis. First and foremost, we have fibrin-forming proteins. These are the proteins that you may have heard of called coagulation factors and cofactors. We have kind of some enzymatic processes that occur during coagulation that the ultimate result is fibrin formation. We also have fibrinolytic proteins. Fibrinolytic proteins are really important because in addition to breaking down the clots that have formed once healing has begun, they also help regulate the fibrin-forming proteins to prevent them from an overabundance of coagulation or clot forming. Now, inhibitors are kind of a funny little category. Inhibitors can be helpful to us and also act as regulators, but they can sometimes get in the way of coagulation and impair the coagulation process to inhibit our ability to clot properly. And we're going to talk about all of those proteins in our upcoming unit or in our upcoming slides once we get into the specifics of primary, secondary, and hemostasis. Now, it might seem counterintuitive to talk about secondary hemostasis first, but in order to get the big picture of what coagulation is, we really need to talk about secondary hemostasis. Secondary hemostasis is a series of interdependent enzyme-mediated reactions, and the purpose of those are to generate thrombin, which is an enzyme. And that thrombin converts the soluble protein fibrinogen, which is its substrate, to an insoluble fibrin. And that fibrin is going to stabilize the platelet plug. So platelet activity is going to occur in primary hemostasis, but that is really just, it's kind of like putting a piece of gum over a crack in a dam. It's only temporary, it's not going to hold for long. So we need secondary hemostasis activity to come in and stabilize that platelet plug to make it more permanent or more stable so that it can hold back the flow of that blood. Our coagulation factors are those fibrin-forming proteins in circulation. And we like to break them down into groups. We look at characteristics that each of these factors have, and it makes it very easy for us to categorize them into families or groups based on these characteristics. Our first group is the prothrombin group. This group is going to include factor 2, factor 7, factor 9, and factor 10. The second group is the fibrinogen group. This will include factor 1, factor 5, factor 8, and factor 13. And the last group is the contact group, which includes factor 11, factor 12, prekallikrein, and high molecular weight kininogen, or sometimes we just call that one homework. Now, each one of these families, again, they have things in common. Maybe it's during production or activity, or maybe they have similar activating events that have to occur. But we're going to talk about each and every one of these factors individually. Don't shy away. Don't be intimidated by the use of Roman numerals. We do use Roman numerals when talking about coagulation factors or naming coagulation factors, but there are other nomenclatures as well. It's important that you know them all simply because they are interchangeable and you may see the name of it or the Roman numeral or both on your exams and in your boards. Let's discuss the prothrombin group. Again, factor 2, which can be called prothrombin. Factor 7 is sometimes called proconvertant or stable factor. Factor 9 is sometimes called plasma thromboplastin component or PTC. Now, factor 9 has a few other names as well. Sometimes we call it hemophilia B. Other times it's called Christmas disease. And once we get into a little deeper into this unit, we'll talk about some of the other nomenclatures for each of these factors. Factor 10 is called the Stewart factor as well. Now, all of these coagulation factors within the prothrombin group are produced in the liver. They are vitamin K dependent, and they utilize calcium as a cofactor, so they are calcium binding. The fibrinogen group is our second group of coagulation factors. Factor 1 is also called fibrinogen. Factor 5 is sometimes called proaccelerin or labile factor. Factor 8 is sometimes called the anti-hemophiliac factor. It's also called hemophilia A or classic hemophilia. And factor 13 is the fibrin stabilizing factor, and we'll talk about why we call it that later on. All of these factors are acted upon by thrombin, and they're not found in serum. Now let's talk for a minute about the difference between plasma and serum. Plasma is the liquid portion of whole blood that has not been allowed to clot. Either an anticoagulant is added. So when we spin down plasma, or we spin down whole blood that's been anticoagulated and we pull the plasma off, everything that was in the plasma in vivo is still a part of that plasma. So that includes all of our coagulation factors, all of the proteins, etc. When we allow blood to clot, all of those coagulation factors and proteins that were once a part of the plasma have now been consumed during that clot making process. And so when we spin down clotted blood, the liquid portion of that is now called serum. Testing within the laboratory can be done on serum for a lot of chemistry tests, but in our coagulation our coagulation testing, we must use plasma because we need those factors to be present so that we can test their activity to make sure that we don't have any deficiencies or any type of clotting abnormalities. The last group or family is the contact group. Factor 11 is sometimes called plasma thromboplastin antecedent, or PTA. Factor 12 is also known as the Hageman factor. PK, or prekallikrein, is also called the Fletcher factor. And then homework, or the high molecular weight kininogen, can also be referred to as the Fitzgerald factor. All of these coagulation factors in the contact group are involved in the initial activation of the intrinsic pathway. One of the reasons we call them the contact group is because when they come into contact with a negatively charged surface, such as glass, kaolin, cellulite, and a few other things, including collagen, it activates these factors. That might not make a lot of sense at this point in the discussion, but as we go along, keep this in mind because we're going to talk about coagulation factor activation in just a bit. So coagulation actually occurs as part of a series of enzymatic reactions, and we call these series of reactions the COAG cascade or the coagulation cascade. And this really occurs on the cell surface membrane. So if you think about our cell surface, we have phospholipids, we have platelet surfaces, we have a lot of different components that can come into contact one with another during normal physiological responses to injury. Clotting factors typically bind to the phospholipid membrane surfaces, so those endothelial tissues and platelet surfaces, and then they rearrange until a complex, including an enzyme, substrate, and cofactor is formed. So all of these components have to be present for successful coagulation to occur. If any one of those components is missing or in short supply, we may have impaired coagulation. Now, this coagulation cascade actually has kind of a branching system. We have the intrinsic pathway, the extrinsic pathway, and then the intrinsic and the extrinsic pathway kind of meet and form together the common pathway. So it's almost like a Y-shaped branch. So starting out on the left, we have the intrinsic pathway, which comes down. On the right, we have the extrinsic pathway, which meets the intrinsic pathway at some point. And then from that point on, moving down is the common pathway. Let's first talk about the intrinsic pathway. The intrinsic pathway is going to include factors 12, 11, prekallikrein, high molecular weight kininogen, factor 9, and factor 8. We utilize a test in coagulation called the PTT. And the PTT is going to measure the activity um, or the function of all of the factors that are happening in the intrinsic pathway. Now, it's not going to measure individual factors, but it'll just show, it's kind of a clot-based test that will show that coagulation is occurring, that clotting is occurring at the appropriate rate or within a normal amount of time. The PTT is a clot-based test, and we want to see if the blood is clotting in response to reagents that we use to artificially stimulate and mimic how normal clotting should be occurring within the body or in vivo. The extrinsic pathway is associated with fewer factors, but it is not any less important. So obviously we're going to have calcium. We are going to have tissue thromboplastin, or sometimes we just call it tissue factor or factor 3. We will then have factor 7, and we measure clotting time for the extrinsic pathway by utilizing a test called the ProTime. Sometimes we call it the PT-INR. And this is, again, a clot-based test just to make sure we don't have impaired coagulation occurring. Now, if we were to have, if we were to run in the laboratory a ProTime and a PTT, and we had a normal clotting time with the PTT and a prolonged clotting time with the PT, we know that the problem lies within the extrinsic pathway. And the opposite is true if our PTT is prolonged, but our PT is normal. It kind of gives us an idea of where to look, where to start looking if there's a problem with coagulation. As the intrinsic and extrinsic pathway converge, we now meet together and form the common pathway. The common pathway is going to include factor 10, factor 5, prothrombin, also factor 2, fibrinogen, or factor 1. And even though factor 13 on this slide is considered part of the common pathway, it really is kind of off in its own little subcategory. It's off in la la land. Factor 13 likes his space, let's say. So there's really no um, testing that can be performed aside from a test that's specific for factor 13. So if a person were to be deficient in factor 13, we wouldn't see a prolongation in the PT or the PTT. What we would have is a problem with clot stabilization, and we would have to do a factor 13 test to verify that it was actually factor 13 that was the problem. So I have included it as the common pathway, but just keep in mind factor 13 has a mind of its own. It's off doing its thing, and it's also the end point of our coagulation cascade. Speaking of factor 13, when factor 13 becomes activated, and when you see a little a after those Roman numerals, that just indicates that factor 13, for example, in this case, has been activated. Prior to activation, our coagulation factors are pretty much just circulating around, waiting to be activated. They don't really do a job until the activation has occurred. But what happens is fibrin monomers quickly polymerize by weak hydrogen bonds, and then factor 13 is activated and converts those hydrogen bonds to covalent bonds. And this results in a stronger, more stable fibrin molecule that is resistant to proteolytic digestion by plasmin. And plasmin is one of the important components of our fibrinolytic system, which breaks down those clots once healing has occurred. Now, if we were to have just a regular fibrin molecule trying to hold together a platelet plug, and this polymerization did not occur via factor 13 or activated factor 13, the clots that are present would not hold. and this is going to kind of sound weird, and it's not exactly the same, but if you think about when you get an injury and you have a scab that forms, those scabs are really kind of tough and they are pretty resistant. And of course, they go away after healing has occurred. Although it's not the same kind of exactly the same thing, that's kind of how I think of factor 18. It's like the hardening of that clot, that stability of that clot, and I always just think of a scab because scabs are pretty tough. Last on our list is our fibrinolytic system. Now, our fibrinolytic system, we have fibrinolytic proteins circulating all the time. Some of them are regulatory, but for the most part, the fibrinolytic system is responsible for dissolving clots and maintain the blood into a fluid state. So if we did not have a fibrinolytic system, we would have uncontrolled clotting. Our body actually has some natural anticoagulants to kind of help regulate to make sure the clotting doesn't kind of get overdone. And it's like a check and balance system. It's really important. Not only does it remove clots once they have formed appropriately, but it maintains that fluid balance, preventing clots from occurring when they shouldn't. It acts locally at the sites of fibrin accumulation without causing systemic effects. So our fibrinolytic system is very localized. It isn't going to cause problems in areas that it shouldn't if everything is working. Now, we're talking about all of these systems as being normal. Things do arise, which can cause some abnormalities, and that's really what we want to focus on because part of our job in the laboratory is identifying abnormal states of coagulation or lack of coagulation. We want to get to the bottom of it so that the doctor can come to a diagnosis and the patient can be treated as needed. All right, so before we end our lecture, I want to talk about a really important component of coagulation testing in the laboratory, and that is going to be our sample. Blood collection and sample requirements are very stringent with regard to coagulation testing. Coagulation testing should be collected in a blue top with a sodium citrate anticoagulant, and we need a very specific blood to anticoagulation ratio. That is going to be 9:1, so 9 parts patient whole blood and 1 part sodium citrate. The reason we use sodium citrate and not EDTA, both of them are great anticoagulants. They keep our blood sampled nice and fluid. EDTA is found in our purple tops that we run our normal CBCs on, but we can't utilize EDTA for coagulation testing, and this is why. EDTA is a calcium chelator. It will continuously chelate calcium out of the sample. And even if we were to add calcium to the sample during our coagulation testing, which we do, calcium is one of our reagents that we add to stimulate in vitro clotting, the EDTA would chelate that out as well. And so it's not a very it wouldn't be useful at all in judging or measuring our coagulation. So sodium citrate is a much better option. And the reason for this is when we add patient sample to the sodium citrate tube, sodium citrate will bind up the calcium in the sample, which prevents it from clotting in the tube. But when we do our clot-based testing, we add that calcium back in, and it does not chelate it out. It's already bound up with this calcium that was present. And so we are going to be able to stimulate very normal clotting within the testing environment. It's really important that the tube is filled properly because if we don't have that very specific 9:1 ratio of blood to anticoagulant, we are going to have either falsely elevated or falsely decreased PT or PTT results. If you look closely at a blue top, if you get the chance to, in class we will look at them. There is a very specific fill line that tells a nurse or a phlebotomist or a lab scientist, whoever is collecting that sample, when that 9:1 ratio is met. Sometimes we have to use sodium citrate to run CBC parameters. specifically when we're looking at platelet problems, because sometimes a patient's platelets will have a physiological response to that EDTA additive that's in our normal purple CBC tubes. And what we'll see then is we will see a lot of platelet clumping. We will see abnormal accumulation of platelets, and we won't be able to get an accurate platelet count using that CBC EDTA tube. Some patients can be run, so patients with this EDTA response with their platelets can be run on a blue top, and we can get an accurate platelet count by circumventing that response to the EDTA by using this sodium citrate. Now, because we have a little bit of a dilution because of that liquid portion or that anticoagulant portion that's in the tube, we do have to adjust the ratio by multiplying our platelet results or whatever CBC parameters that we have run by 1.1. So if I had an EDTA clumper and I ran their platelet count on a sodium citrate tube and say I got a platelet count of 220, I would just multiply that 220 by 1.1, and that would be my final platelet count.